All right. Welcome, everybody. I can't see you, but I know you're there. My name's Bobby Slack. I'm at Scripps Clinic down in San Diego. It's my privilege and honor tonight to present to you with my esteemed colleagues here, Dr. Mullen, Dr. Kim, and Dr. Harrod, who's going to join us on some of the advanced materials that we are privileged to be able to use in our practices. And it's a little bit of an evolution of my thought process that we'll go through, and then of course we'll dialogue with Dr. Mullins, Dr. Kim, and Dr. Harrod, and they're going to show some cases along the way, and much of that will be aimed at letting you get a preview, if you will, and better understand Curtiva's trabecular peak technology, which I think is transformational in many ways in how we use materials for interbody and other fusion devices in spine surgery and probably beyond that. So without further ado, I'm just gonna run through a few things. I will try to keep this a little dialogue oriented with our other faculty because I think you'll gain some real insights from them as well. I always want to start some biologic talk with Marshall Urist, who, for those of you who don't know him, he was an orthopedist, but really popularized the work in BMP2 discovery and was the genesis for a lot of what has gone on with many of the BMP and other sort of base bone protein specific modulations that we've seen over the past 4 or 5 decades. So really a grandfather of what we're talk about in biologics. George Winter is another great mind in this space. He was the founder of the European Society of Biomaterials, and he really discovered in 1970, shortly after Urist, that he could stimulate bone formation in soft tissues using a synthetic polymer sponge. So really this concept of being able to induct or induce bone formation in areas that it typically wouldn't be on the heels of the right structure. As you know, we've seen a long evolution of interbody devices. We've used allograft bone, autograft bone. You see there the first use of BMP in interbody spaces with an LT cage in the cage rage days. And then we moved on to Peak, as you see in the bottom right, and then 3D printed titanium or metal cages on the upper right, all directed at trying to get a better result, more reliably, cheaper, lots of different reasons to make the move. And in many cases, with the Peak, a desire to radiographically affirm our fusions. Peak was originally introduced in the late 1990s. And in the form of the Brannicket cage. It was reinforced with carbon fibers and really first contemplated with a posterior and lumbar interbody fusion approach. And the first FDA trial was back in 2000 and demonstrated what was a reasonably good fusion rate at that time. Um, the peak material is polyether ether ketone, and it's essentially a polymer. It was commercialized outside of medical use many years prior to implementation in orthopedics and spine. And it was attractive because it was stable, resisted chemical and wear, and was susceptible to compression molding and other extrusion modalities to allow us to form it into the things that we needed or would like to use it for, and we could sterilize it to boot. In addition to that, it just happened that Peak was relatively similar to bone in terms of its modulus of elasticity or structural property, which obviously made it favorable to consider placing it next to and load bearing against the bone. So that was sort of a nice advent to use in spine, particularly when we were often putting it between two bones and loading it. This finite element analysis that you see here examined cadaveric specimens within the context of peak interbody spacers and really nicely found that the end plates were stressed less with peak implants And the von Mises stresses were greater with the bone graft within the peak, which in combination lets you know or is ideal in the sense that the bone's less likely to fail than the titanium, where the stress is applied or the load is occurring at the peak bone interface, and the bone inside the graft is stimulated to heal, to form that fusion that we desired. So this was one of the first looks at a comparative analysis between titanium and PEEK as materials and their material properties. So lots of reasons why PEEK. We talked about some of them. The other aspect that I mentioned is that it's radiolucent. We have no problem or very little problem ascertaining that we've had a fusion occur when we're looking through PEEK on plain radiographs, where that can be challenging, if not impossible, with metallic implants. So before I go on from there, let's bring in some of the other faculty. Jeff, Dan, talk to me about your historic use of implants. Did you always use what you're currently using? Did you used to use just straight plain PEEK, or did you get started later with porous PEEK or other newer technologies?
Yeah. So I am not sure if I'm the unusual trajectory to getting into Inspire. I was more of a titanium user. So I did a lot with some of the early nanotechnology on titanium implants. And because I believed in that and surface osseous integration. However, I was concerned as having some subsidences with those with titanium cages, as you know, is a concern. So then I started looking at some different opportunities, and I was familiar with some of the work out of ECU on this peak printing with the surface materials that Inspire is, and started using those. And in my case, I think I'm really happy with the fusion rates, but also as important as the lack of subsidence.
Right. Good deal. Anything to add, Dr. Kim?
Yeah, so I finished fellowship about 5 years ago, and fortunate to be at a time where we've come into these 3D printed, more I would posit more advanced interbody cage technologies across the gamut of materials. So I first started using titanium, and I used a 3D printed titanium cage both in the lumbar and cervical spines. And then heard some early studies regarding there's a separate company's porous peak. It wasn't a 3D printed porous peak. It was like a salinity, reduction porous peak, and there was some significant data there, early data. And I started doing the research, and I think more and more convinced myself that structure had as just about as much to do with biology than the actual material itself. And then combined with the some of the other properties that this device had, I made the switch about 3 years ago and haven't gone back in the cervical spine. I still do use some titanium in the lumbar spine, and that was for me primarily the hesitation was one, the lack of options, but two, just I just didn't know how the biomechanical stresses would hold up in the lumbar spine versus the cervical spine. But I'm starting to change my philosophy on that as well.
Great. Well, that gives us a nice inroad to this next discussion. So why not traditional peak? You guys are a bit younger. For a time, that's all we had. We had traditional peak that may have some friction-oriented surfaces to prevent expulsion, but really had no biologic capacity. Hydrophobic surfaces, peak is as a material hydrophobic, smooth surface, which, as you just mentioned, Dan, does not provide any incent for the bone to apply itself, grow, interpose with the device. So biologically inert, and in that case, you get fibrous integration. And in my opinion, you end up having a nuclear blast the area to try to get it to heal, which is just the opposite of what we'd like to do because there are collateral damages that occur with those big biologic throws that try to get the bone to heal through a bioinert device. So that was obviously a problem. Now, traditional spinal fusions had their own issues. The autograft availability, allograft would often be either challenged supply, not the right morphology. Allograft can sort of crumble and collapse, and while you may not get subsidence, you get failure of the restoration of height. Because bone goes through these inflammatory repair and late remodeling stages that take time, and you need something that's got some durability to get through that. Our knowledge of bone healing, apposition, on growth, all of that stuff is really learned on the heels of dental and then orthopedic surgery background, the total joint reconstruction, folks that have really made orthopedics highly reliable with hip replacements and some knee replacements and shoulder replacements have done so with these on-growth type surfaces. So there's a real recognition of the surface topography, the structure, and how that allows for bone to interact, not only to heal, but to be viable as a living tissue that absorbs, responds, and becomes stronger because of the stress around that is part of our living tissue. The convergence that happened between graft and implant technologies, you can see here, happened in the 90s and 2000s. And that was this awareness that porosity, pore size, that we learned from authors and scientists back in the 1950s and 60s and led to these breakthroughs in the 90s and 2000s so that we can make these sorts of surfaces in a variety of ways with a variety of substances and have bone respond in a favorable way. And that led to even further work at the nano level by Barbara Boyan and others that discovered that at the nanomolecular level, you get a stimulation of cells at both attachment, protein releases that stimulate and allow for bone to be healthier and part of the healing process, not only to the implant itself, but to propagate bone through and around it. And then the most recent sort of awareness was around this immunomodulation phenomenon, in which case the structure, properties, as well as the chemistry of the surface provide for inflammatory differential, meaning pro-inflammatory or pro-healing sorts of environments. And in the case of bone healing, we want those M2 macrophage pro-healing sort of immune cell differentiations to occur. So in the end, we've gone through a ton of different implants. Welcome, Dr. Herod. Hope the case went well.
It did. Thank you. Thank you, Bob.
You bet. We've gone through a ton of iteration on both implant sizes and shapes and surfaces. And much of it has recently been modulated by this understanding there's a mechanical implication to bone healing in the sense that the pore size and porosity through growth may demand even differential sort of mechanical and topographical features. And as Dan pointed out, we're all worried about the stiffness of the object and our ability to match the bone that we're putting these things in so that we do decrease the risk of subsidence or failure, offload the screws, or don't demand on the screws quite as readily so that we have better reconstructions. And in doing all that, adding to that the chemistry, which allows for bone to be happy, cells to be happy, and for the implant to propagate well. This is a look at sort of this transition of implant surfaces and features from smooth to rough to porous, and really how that's evolved over time from the sort of toothed or ridged, which was really just directed at mechanical prevention of expulsion, to the coating of these implants or the acid etching, things that provided some of those features, and then more recently, the addition of interconnected pores and a trabecular nature of these implants to allow for bone to really propagate into and through and provide some mechanical integration. In terms of porosity, the topographical impact, normal trabecular bones about 70 to 98%. It's a good number to have in mind as you're evaluating these sorts of different structures and what they should be targeting. Lower porosity generally supports osteoblast differentiation, but higher porosity, better ingrowth and higher cell viability. So there's a little bit of competing directive there. Matching bone or being somewhat similar to bone would logically make sense if you're trying to get the best outcome in terms of bone through growth and integration. Klaywitter looked at this back in 1976, even with different substances, different materials, and figured out the same sorts of things despite different property characteristics of those substances. And about 100 to 135 microns is where he found the pore sizes to be optimized with bone. And at the cellular level, as I said, with the change and the awareness that structural topography makes a difference, there's notable increases in fibrin clot retention, particularly on porous and rough surfaces. And you can see that up here in this top right graph that you get this sizable increase or escalation with the trabecular peak over some of the other materials out in the market. And it's not that you don't get it with other things, but you get it in spades when those circumstances are optimized. The other thing I think bears some important discussion is this whole concept of mechanical interlocking. When we're doing spinal reconstructions, we would preferentially like there to be as rapid a stability as possible. And I would say that goes for cervical, lumbar, thoracic, and really regardless of what fixation you use, because the fixation, as we all know, is provisional. It's there to hold until things heal, but there's a cyclic loading that happens. And we've all seen loose screws even when the body goes on a heel, or certainly loose screws when it doesn't go on a heel. So there really is a race against time in that early mechanical stability, if it can be afforded by the interbody devices, is key to success. And when you have a look at how that occurs with different substances, you can see here over on the right this concept of bone locking, as you see right here, to the material versus in areas like this where you see fibrin or fibrous inner space between the substance and the bone itself, if there is much bone. When you get an undulating or growth of bone in versus just on a surface like this, it allows you to have mechanical stability from expulsion, from shear, and again, that will ultimately lead to a more favorable environment for fusion and less reliance on the fixation and its propensity to fail with cyclic loading. And here's another look at that concept that you can get with porous titanium. You can get it with porous PEEK, more or less. Now these can be more limited in how far the bone grows in, but the point of this slide is to really represent how much improvement in strength that you get from that mechanical stability with a 4x integration to expulsion, with this integration and with the porous PEEK 3x over smooth versions of those same substances. So the mechanical stability and appositional on-growth or ingrowth, as we say, is really critical to success. Down to some of the cellular level matters that occur with these different substances and the differential impact of porosity and topographical characteristics in PEEK. With porous PEEK here, you can see this differential increase in osteoblast maturation, mineralization, and vascular signaling, which is probably key to some of the healing. So this is obviously at a cellular level that you're seeing an impact just to the topography of the implant. again, the surface matters. This is a look at both the macro and micro scale and its impact, but all the way down to the nanoscale, you get differential impact on the cellular messaging and cellular attachment, adhesion, and behavior. So all very important in their own ways. And really, we're looking at all of that to get the perfect implant. Why do we care about material properties? And this is sort of a moving target. I know it's a little hard to make sense of it, but we care because of what you see here. We see a traditional titanium cage settling into the bone. Does that happen all the time? No, of course not. But there's a clear mismatch in many cases that we hate to see. And the modulus of elasticity just basically of these material properties will obviously confer some benefit to something like PEEK relative to bone. It's very close to cancellous bone, which would be ideal. But when we have it sitting next to or adjacent to cortical bone, so it should be a little less robust in its tendency to settle into the cortical bone. And these are the other material properties you see on the right. And obviously, titanium is one that you see quite frequently. So we're trying to match that to a large degree. Where I think there's discussion to be demanded is the modulus of elasticity the real story? And I would say no. I think this is more about structural stiffness and how we can manage that. The structural stiffness is really what's going to lead to failure, not necessarily the material property itself. And if we go down that road, then we have to look at the volume of material, the amount of distribution of force that we apply to the end plates, so the surface area, and then the architecture of the implant and how it can be modulated to both distribute load, maintain its own strength, and then obviously minimize the subsidence risk. And we'll talk about that a bit more. But since we're on that, and I know both Jeff and Dan talked about that, let's go ahead and pause there for a moment and ask some of our faculty, maybe Dr. Harrod, since you just jumped on, how do you think about a structural stiffness or an implant characteristic in that realm when you're evaluating these 3D printed devices, PEEK devices, trabecular PEEK devices? Give me your 2 cents on that.
Sure. Thank you. Thanks a lot, Bob. Yes, can you hear me?
We can hear you.
Okay, terrific. Well, as far as, I think it's very important. That's part of the reason why, my bias is somewhat against titanium. Now, I did obviously, I would say about 10 years ago, I did try some titanium, but especially for multi-level fusions, I found it to be too unpredictable, especially in patients that had any type of comorbidities that would put them at risk. And compared to what I'd previously been using, which, to be honest, when I trained under Alan Hillebrand, and a lot of his, when I first came out, I was just using a lot of allograft and corticocancellous allograft, and sometimes fresh frozen allograft, because I was trying to find something that wasn't that stiff. But I think as the advent of cages with larger surface areas and that kind of swayed me to come over towards using cages rather than structural allograft in cases where I didn't want to obviously use iliac crest autograft. But I certainly found that even a number of the titanium cages for me were lacking, especially if it was more than a 2-level construct that I was wanting to avoid a posterior operation at the same time. I think that certainly this implant certainly feels softer, and it does feel less stiff. And certainly, I think most of us, when we've used iliac crest autograft, it almost has that almost a little bit of a, it's not spongy. It certainly has support, but the stiffness does feel right, if that makes sense, even compared to a number of different PEEK products that I've used over the last, I'd say, 10 years.
Interesting. Anything to add, Dan? I know you've used it for quite a while now.
Yes. Can we go back to the original question? I guess just
Yeah, it was essentially around your move in the direction of trabecular peak in relation to its and how you think about structural stiffness, how you think about what we've been trained in modulus of elasticity, but its relative sort of irrelevance, I would say, compared to structural intent or
yeah,
structural
yeah.
behavior and stiffness of the implant.
Yeah, I think that's a great question because I think if we get really granular about, we talk about things like modulus and Wolff's law, but when we talk about I think if we're talking about a single level cervical fusion, I mean there are multiple components involved, including sizing of your cage, how flexible the posterior elements are, and then based on that, and your plating and what stress shielding you're doing with that. Um, my thought in terms of, I think there was a nice question on the chat about have I noticed increased subsidence from the change from a porous titanium to porous peak. I would say, honestly, I haven't done the statistical analysis, so I'm not going to make that claim, strongly. But I would say there have been instances in poorer bone, especially in the cervical spine, where I am just not seeing the subsidence that I would usually I would be expecting. I think with my previous history of metal cages, um, I mean I would say even with the porous peak, because although the elasticity of or sorry modulus of elasticity of titanium can't be changed, the effective modulus of a cage can be softened to near bone or less than bone in some cases. And so I think these newer generation titanium cages do a good job. Um, but I would say, honest opinion, over hundreds of levels, from a surgeon's heart, I strongly instinctually feel safer when I'm putting in the porous peak versus the titanium in a kyphotic, osteoporotic patient. Um, and then I feel because I tend to use a very thin plate, a 1/6 plate, and I angle my screws. I think that this thing has less of I feel like there's a less stress shielding event, and I can trust this cage. I think, like you said, Dr. Eastlack, to perform more of that early um, on growth, appositional healing, spot welding, that whatever we want to call it, that provides that early security. And I think that is key to the long term good results that I've seen.
Good point. Since we're sort of on this train, one of the things I've heard as a concern is, okay, it's softer, it matches the bone bearers, it's strong enough, and any thoughts about that? And I'm happy to answer too, but maybe Jeff, do you know enough about that, the trabecular peak process to weigh in on the strength of the cage, even though its relative or effective stiffness is well matched to Cancellous bone?
Yeah, I mean, I think you can answer that in detail if you'd like, but if all the testing, everything's demonstrated the safety of it, efficacy of it, and in our experience, the strength of it is more than sufficient and has leaded to maintaining Lyme for me. But you've seen my cases with thoracolumbar cases where there's more force on the cages to not only allow that, but also prevents subsidence. And so all these comments about titanium versus 3D titanium versus peak versus trabecular peak, I think we just are trying to find the balance between the best of both worlds and the stiffness and as well as the surface technology of titanium, the stiffness of peak, and this trabecular option, I think, balances out as best as currently in the market.
Right. Yeah, absolutely. Yeah, that's my understanding as well. The manufacturing process allows tremendous strength, even though the effective stiffness of the structure is more ideally matched to the cancellous bones. All right. Conformation of fusion, obviously, a challenge with metal implants. I don't think any of us have an easy time assessing fusions with plain X-rays anyway when we're using metal implants, metal interbodies. Certainly, you can do flexion extension views, but it's hard to really get that confirmation. We all love to see the bone communicate from one end to the other, or even to have appositional on growth, which you may be able to see a little bit with CT, but I find that difficult with radiographs. Your The CT that we will typically do is obviously expensive. Comes with radiation. So I think that's a sticking point in my opinion for most of the metal implants, despite their current favorability. And I think an area of real both concern and promise for returning to a more biologically friendly but radiographically favorable peak type product. The new class of implant, the perfect implant, if you will, I think really is going to bring all these things to bear. A mechanical property that is good, as we just talked about, relative to subsidence, compaction. It matches the cancellous bone, preferably even on the osteoporotic or osteopenic spectrum more aptly. That it provides that early on-growth appositional attachment to the bone so that it offloads the remainder of the construct sufficiently and facilitates the fusion or disallows any pseudarthrosis formation. And then on the structural side, at the micro and um, uh, nano level, that it's stimulatory in the environment for cell migration, behavior, and bone growth, which also has a chemistry source. And then it minimizes the need for really additional biologic agents of any substantive need level. Obviously, if we can use these implants and dial way back on the cost of the biologics that we're typically having to throw at the situation to get healing to occur, it's a tremendous benefit for our healthcare economic system, which is struggling, as we all know. And frankly, it offloads some of the complications that we can otherwise see by using some of the more potent biologics, as we know as well. And then finally, the perfect implant's going to have those favorable imaging characteristics so that we can cheaply and quickly affirm that the healings occurred as we had hoped. So that gets us to the discussion about this trabecular peak. And as you can see, it really has that trabecular appearance of what bone would look like. And you can see that that's also covered or infused with the HA technology. So it's providing not only the right structure, it's providing the right chemical environment to drive bone to grow and heal and propagate. So it's really harnessing both of those issues of structure and chemistry. This is a look at Inspire and the trabecular peak, and you can see how closely it mimics human trabecular bone. So from a cellular perspective, this is going to look like home, and cells will want to migrate through and set up shop. Barbara Boyan looked at this and looked at the structure, and she's done this over decades and seen most of the evolution of what we're talking about in biology and structural inspiration of bone healing. And you can see her hear her quote that it is conducive to ingrowth and through growth of bone, and something that she has not seen before, meaning we have not seen it before because she's usually on the front lines of understanding. And the picture on the right is just looking at the cells adhering to those peak strands that you saw in the prior slide that mimics trabecular bone so well. This nano texturing with HA fused technology, you can see in this middle picture at high magnification, that really gives you this ability to not only mimic the bone structure, but to induce bone to grow into for cells to do the right things in developing, growing, and propagating bone. So again, it's structure, it's chemistry that is put into these Inspire products with the pore size distribution that we talked about, right in the sweet spot for promoting osteoconduction, and the micron and nanoscale surfaces providing for enhanced osseo integration. And importantly, all of these channels provide for interconnected porosity. So really, there's no stopping the bone from moving through and enveloping this as though it's its own trabecular structure internally. Another look at a high-powered magnification. And really, this is just to highlight that this HA fused surface modification is exceptionally thin. In that way, it doesn't override the structural appearance to the cells, but does what it needs to from immunomodulation and propagating of cellular behavior. And this led to the FDA providing a nanotechnology designation in 2026. And I think that's testament to the great work that the technologists, Dr. Irby and others, have done in leading the charge on getting this sort of new technology and implant into the right trajectory. Barbara looked at this further on the cellular and cellular propagation and messaging level, and found that that sort of surface does in fact upregulate vascular endothelial growth factor A and encourages bone formation. You can see that over the course of a 14 to 15 day cell cycle, and suppresses the inflammatory response, and is favorable to what we talked about at the beginning, which I'll sort of reiterate here, in differentiating macrophages into this M2 lineage, which is where we want to see these cells migrate to for bone formation, versus M1, where you get the pro-inflammatory behavior and fibrous tissue and other sort of obstructive pathways to bone healing. This was there was a study that was done looking at material properties of PEEK and the physical features of an interbody fusion device, and whether that could be modified to improve osseointegration in vivo. So this was obviously trabecular PEEK, and human mesenchymal stromal cells were found attached to and migrate through the porous PEEK, just as visualized by the micro CTs and confocal laser microscopy. And they further found that there's a pro-inflammatory macrophagic response. And in the end, this is really the conclusion that I'll share with you on this slide. And it was that 3D printing using this sort of additive component of the HA service of the plant, including the mesenchymal stem cells and progenitor cells, as well as macrophages, to create this microenvironment that impacts the regeneration of bone, implant stabilization, and osseointegration. So it's really doing all the things that sort of individually were discovered in basic science testing, and doing it mechanically and on a cellular level. Bill Walsh, if those of you who don't know him, he's really contemporary with Barbara Boyan, and a world's expert in bone healing, bone integration, osseointegration. And he studied implants out the wazoo, titanium, PEEK, coated PEEK, trabecular PEEK, porous PEEK, and he's been quoted as saying this is the most significant amount of bone he's seen in 27 years of studying implant materials, particularly with respect to the location, meaning how deeply these how deeply the bone grows into or through these channels is quite strikingly better with trabecular PEEK over much of what he's seen, even in these animal models, which can be less challenging than human models. But as an example, you see here different devices. On the bottom here, you see a competitive comparison devices, and really bone can attach to the surface, but you see fibrous tissue over here on the right with the comparison, and fibrous tissue on the left with the other comparison versus what you see here at 12 weeks at the same time point with the Inspire type trabecular peak technology. There's really it grows all the way through that device and implant is fully immersed and engulfed with that bone. We won't belabor this too much more because I want to get to your cases and have a chance to chat through those. But this is just a look at where Inspire and trabecular peak sits in the realm of this structural stiffness. And you can see it's more favorable than regular peak even, and really is consistent with or approximates cancellous bone in terms of gigapascals. And that's clearly going to be a benefit to our patients to have that sort of matched condition. So bringing it all together, and we've gone through these points as a faculty with you, but when we think about the needs, what our sort of perfect implant looks like, you could break it down into the features of the implant. And if you look at bone match modulus, relative stiffness, structural stiffness, however you want to term that, we're really talking about subsidence risk, which is obviously a moving target. But the better we can match trabecular bone and distribute load, the better we're probably going to perform. And that really is taken care of quite readily and a winner in the sense that trabecular peak really gets us where we want to be in that respect. In terms of mechanical integration, so how do we get an implant to give us structural support early and quickly to offload the construct, and frankly, probably to allow for patients to feel better quickly? We need the right porous architecture, porosity, interconnected pores, and through growth, and that really is provided for again in spades with the trabecular peak concept and device. So you not only get the right on growth and positional growth, you eventually get a facilitation all the way through the device, and it can become one with the bone and not just be reliant on surface on growth or any other sort of halfway process as you might see in most of these other implants. The surface chemistry, obviously a clear Achilles heel of prior peak utilization, but with this nanocrystalline HA, you really get the benefit of the chemical nature, hydrophilic nature, and stimulatory nature of the implant now that you wouldn't get with some implants that either don't have that at all, or obviously traditional peak. And you get it throughout the implant. It's not just a coated surface. You get that stimulation both on the inner core where you might put graft as well as through the entire interconnected porosity. We'll kind of gloss over this because this really fits in with what I talked about with the on growth and the early stability. And then behavior and osteoporotic bone, probably best served in what I said, to have this distributed force with the least amount of modulus or closest match to cancellous bone that we can get. And there may be even a role for future modifications where you dial it back even more. So there's greater matching of the aspects to severely or partially osteoporotic bone. And then lastly, the radiographic fusion assessment. That's clearly going to be benefited by a peak type device. And the Inspire trabecular peak is a clear winner if you factor all those other considerations into the picture. So we'll talk about this really briefly. This is the reliance on supplemental biologics, and this is certainly my opinion. But I think if we can get osseointegration and rely on surface integration, we really are going to be on this nice race downward in terms of our graft dependency. And we can really rely on local autograft or very cheap biologics to get amazing results on the heels of the advancement in the technology that we're being allowed to participate on. So that's sort of the end run of all of the didactics and discussion points that I had. So now we'll kind of dive into. I'm going to ask Jeff to go through his case. And Jeff, I've got these slides up, and I'm happy to just sort of work through them so we don't have to waste any time sharing. But if you don't mind hopping on,
Yeah,
go through
that's
it.
great. If you can just click through them, that'd be great. Save us some time here. First, I want to thank Curativa for inviting me to be part of this. And then next, thank Bob for that great talk and introduction. I think Bob was a friend of mine, but we didn't go over these slides beforehand. So I think he touched on a lot of things that I'm thinking as well. So without further ado, we can jump into a couple of my cases, which are not the typical San Diego patient. So we're up here in Buffalo, we don't get a lot of sunlight, so we get more osteoporosis. This lady came in to me, 64-year-old lady, osteoporosis, psoriasis, on steroids, back pain, some radicular pain. The clinical picture was she failed some conservative management, intact on exam, but bad radicular pain. Next slide shows the MRI, I believe.
Yep. X-rays.
Or sorry, EOS X-ray. So relatively okay alignment. Some foraminal narrowing, disc degeneration, 4, 5, 5, 1. Talked to her about a decompression fusion at those levels. As I mentioned, she's known osteoporosis on steroids. So not the ideal candidate for some fusion surface. In my previous life where I used a lot of titanium, I'd be really worried about the cage subsidence of this patient. Fortunately, I have access to Inspire and Curativa and wanted to use it for her. So achieving fusion without sacrificing the cage subsidence. Planned for do the surgery in my surgery center. So at my surgery center, we do have limited biologics. Touched on your last point in Bob's talk. So for all my fusions there, I really only have DBM or autograft to use for my packing the cage and push air gutters, so on. Next slide. So she went through surgery, uneventful. Per my routine practice, I get x-rays 3, 6 months, 12 months. If you click here, they'll zoom in showing the fusion at 3 months. You can see some ingrowth through the cages there. Next one, 6 months, increase a little bit more. And 12 months, I think, is pretty well fused. So nothing too exciting here, just showing a hazardous fusion surface for this patient and went pretty well. Next slide just, I think, talks about the clinical outcomes, and shows EOS. So maintain her alignment with that, doing well post-operatively. Has complained of back stiffness, which, believe it or not, happens with fusion. So I'll put that in the win category despite her comorbidities. So we push the ability of Inspire and Curativa with this lady. So for the next case, I went even further. Click on. So another lady, rheumatoid arthritis, she's obese. She's on chronic steroids for adrenal insufficiency, known osteoporosis, pretty bad picture all around. Again, failed the conservative measures. Please click for next picture. So pretty severe degenerative changes at 4 or 5. So talked to her about doing a fusion. Also noticed the sarcopenia and just diffuse adipose tissue. This probably doesn't project very well, but for a lot of my patients, osteoporosis, obviously there's a lot of discussion. We have a whole different topic about DEXAs versus VBQ scans versus Hounsfield units. As you can see here, she has relatively low Hounsfield units. I think the average of those three is somewhere around 60 to 70. So poor bone quality, very bad clinical picture. And also you can see at L3, she already had a compression fracture at 3 and 1. So I have a lot of worries about this cage subsiding.
Yeah.
Next.
You think? Pre-treated? Did you treat her anabolic wise or?
Yeah, so most of my patients do get some sort of anabolic treatment, but that can only go so far. I can wait so long for them. And the only other thing is I do, for some of these really ones we're about, I do this nesting technique for these anterior teeth cages where I sort of stack them to get a little bit more end plate coverage. This is sort of my best hope, I think, to try and get a good fusion here. So same thing done in my surgery center, limited biologics, these 2 cages. Here's her pre-op EOS, so terrible kyphosis all around. This is an ugly case, but really bad stenosis. So this was a sort of a sympathy, tugging the heartstrings. She taught me knitting surgery, and I was like, all right, I'm going to regret this. Did surgery, 2 weeks post-op, she came back in with like terrible back pain. So I'm telling myself, oh no, she's already subsided or breaking down already. Got x-rays. Here, click on Bob. It shows everything stayed in place, so it didn't subside there. But also just showing there's no real clear fusion there. Obviously, we wouldn't expect that at 2 weeks, right? But this is just an interesting case study for this discussion that despite having worsening back pain, it's just post-operative, nothing, hardware's look good. So we got it through that. Came back 6 months. Her EOS actually does look a little better somehow. And then you can start, if you click in, I think you'll see the zoom in there actually had bone ingrowth throughout at both those cages. So despite the terrible story I gave you guys, this is a win. And I was nervous for a while, but it worked out well. Click, I think that she's just doing real post-op to the last slide, saying she's actually moving on to, she had a shoulder injury or something, is going to get orthopedic surgery.
Wow. Impressive. Any comments, Dan? Chambliss? No?
No, nice technique. I like the 2-level TLIF at the surgery center. Very nice. The stacked cages are nice and good job. Very challenging patient population.
Thank you.
Really.
Yeah, that's amazing that held up there. I would never have done the T-lift there.
There you go.
Looks great.
Well, yeah, look, I mean, that's a testament to the potential. A lot of us wouldn't, because the subsidence risk with T-lifts historically is 20-25%.
Yeah.
But maybe there's a better new widget that does that because it's better suited for that purpose. So great. All right, let's jump to Dan. Tell us what you got, Dan.
Okay, so we've got a case of multi-level cervical fusion. This is, I mean, nothing novel. It's a patient that we all see in our clinic every day. Older gentleman, 65. He's got some cervical myeloradiculopathy, mild myelopathic symptoms, more neck pain and radiculopathy. He's not got a whole bunch of risk factors, pretty healthy, non-smoker, but he does have this remote history of a lumbar fusion with a non-union, and that always like makes you kind of tilt your head a little bit. I run a sort of a lab panel on all of my non-unions, and I didn't find anything out of the ordinary. I did not, given the timing of it, I often get DEXA scans on almost everybody, but on this gentleman, without other history, I did not get a DEXA scan on him. His, bone density seemed okay, but he could see he's fairly disabled. His NDI is 46, and he's hurting pretty good. All right, next slide, please. So these are his radiographs. Obviously, he's got a mild kyphoscoliosis. And, when you see this kyphosis in an elderly gentleman, at least for me, you always worry about like cage failure of a standalone or, cage subsidence, in my opinion. And I think for most of us, we start thinking about, oh, maybe we need to back this up. And I think this case is especially prevalent for me in this era, because I think we are coming out with more advanced ways to do a circumferential fusion, and to less minimally, back up an ACDF when it gets to multi-level, given the historic data that's out there, which, personally, I think is a little bit outdated. But that being said, or some maybe misleading or outdated, that's an aside, but I think this cage and the results that it's given me, especially early, have given me the confidence to do multi-level fusions without backing up these patients. Knee-jerk reaction. I think especially relevant in these cases is that, like Dr. Eastlack had mentioned, there's definitely a shear force coming on these cages in these patients, and I think there's a especially prevalent race to a spot weld prior to a solid fusion, if you can get there. So, anyways, next slide. that's sort of my reasoning for why. This the MRI and the CT scan. Like I said before, he's got this kyphosis, his scoliosis, and then he's got central stenosis at both 5.6 and 6.7. He's got a pretty good foraminal stenosis at 4.5. Now, 3.4 is the question. That changes this guy from a 3 level to a 4 level, and I think that's a discussion we can have for a very long time about the theoretical risk of a pseudo, or what is the risk of a pseudo of a 4 level. In my opinion, in a guy like this, almost 100%. You're just so. He's not radiculopathic. I think I can get him lordotic through the lower segments. He's got no central stenosis there. I had this discussion about adding 3.4 to my construct, and ultimately we decided to just address the 3 lower levels, which should be the axial cuts on the next few slides. As far as this myelopathy and his MJOA, he's coming back to me. I initially saw him. He didn't have any myelopathic complaints, but he comes back to me, his 6 months later when I sign him up for surgery, and now he's dropping things with his hands, etc. So this was my ACDF. It's a 3 level. As you can see, I've gotten good lordosis through those segments. And I do use a smaller or a thinner plate, like I alluded to earlier. And I just really rely on those cages to do the work. So next slide.
And what biologic did you use, Dan?
I use local autograft and DBM. I too think that in this day and age, we're ripe for the picking in terms of our cost, in terms of the overall healthcare landscape. And I think if we can find ways to do things just as good, if not better, cheaper, we need to start really looking at those things as a whole. Not that I don't have available to me in my hospital iFactor or Magnetos or even BMP off label, which some people are using. I have found with this cage my results now. Obviously, I've done hundreds of levels. I've had count on one hand pseudos, but I've been very, very pleased with the results with just DBM. And local autograft that are morselized. So 6 weeks, 3 months, 6 months, and then at a year, you can start to see even on radiographs. It's hard to see here on the projection, but especially down at the caudal level, there's definitely bone growth through the cage, and that's one of the beautiful things about this. I don't have to rely versus the metal use I was using earlier. I don't have to rely just on the patient telling me their neck feels better to say that the
Right.
fusion is robustly going. I can have a radiograph, and I don't have to send them all for consecutive CTs or any CTs at all most of the time. This gentleman, I did get a CT at a year, and I think that's on the next slide. Well, this is the year mark here. And as you can see, there's thorough through growth through the graft window, a solid, and the top level. You go off one slide on the sagittal, and it looks robust, and there's no, all of us are used to seeing that like giant cleft, that develops in the middle of these of the peak cages. I'm not seeing those on the few CTs that I've gotten, and I think a really salient point here, that's kind of very subtle, but if you look on the coronal and you start seeing little outside of the graft window, you start seeing little pockets of bone developing within the area of the cage, and that's the through growth. It never shows up as like as radiopaque as the graft window, but I think that's just proof that the through growth is developing in the trabecular network, which gives me and then obviously that 3.4, it's still kyphotic, hasn't slipped anymore, and the patient has been doing really well. So the next slide I think is just proof of that. Well, this is at a year, just kind of showing the difference between it and his alignment, and he's happy. And then the next slide
That one here.
This is his O-bird. And on the right column, it's busy, but at the top on the right column is NDI starts at 46 at a year. It's 14. And then his VAS arm and neck went from 8 and 8 to 1 and 2. So, didn't have to
Happy.
include that cephalad level. He's 65. I mean, if he has to come back in 10 years and get this, 3, 4 done, sure, I'll do it.
Well, it doesn't look like you're going to have to.
Yeah.
Good. All right. Well, without further ado, thank you, Dan. Let's get to Dr. Herod. He's got a case to show us as well. Go ahead, Jim.
Sure. Yep. You can go on and skip through. I mean, I'll keep it quick. Essentially, 62-year-old lady. She's this is Louisiana. Nobody can drive. It is the highest risk in automobile accident rates, I'd say, in the country, and that's pretty backed up with some actual data. But anyway,
And attorneys.
what's that?
And the number of attorneys.
Absolutely. But anyway, 62-year-old lady that had radiculopathy. She basically had failed everything in the world with pain management. Had sent her over to me. Next slide. And similar to what Dr. Kim was showing us, I mean, obviously your classic 5 to 7 stiff segments, and then there are degenerative spondylolisthesis at 3, 4, and 4, 5. Okay, next slide. So we were planning for, and she did have some cervical stenosis up there, but a pretty good bit of neck pain. We did decide to do a 4-level rather than a 2-level ACDF from just 5 to 7, and that was our plan. Okay, you can go ahead.
Can you see it?
Perfect. Yeah, and this is early on when I was still waiting for the 5 millimeter cage. I mean, this is one of the earliest ones that I'd done. So as you can see here, the 3 porous peak cages at 3, 4, 5, 6, and 6, 7, and then we had to modify that with the 4, 5 level. But early on, as well as certainly later on, I mean, this lady really has a very solid fusion with, I would say, acceptable alignment compared to what she had, which is a little bit of kyphotic deformity with those instabilities. So I'm very happy with the radiographic, the way this looks early on as well as long term. And then next slide, we've got CAT scans, both early and late. I can't remember if she got into a 9th accident or not early on, but it was beneficial to see her CAT scans there. Both early and late, really showing a robust fusion. And this has really been my experience. My only the only critique that I do have is I hate that we have to include a graft channel at all. I think that just the fact that the FDA is and obviously you have to include a graft channel, but my preference would just be literally a block cage in with this new Inspire technology, in my opinion. Okay, and I think. Yeah, did I have the second case, or is that the one you have, Bobby?
Yes. You got a second here.
Okay, that's fine. And you can go quickly here. 74-year-old lady with myelopathy, previous 5 to 7 ACDF. Okay, next. And there you go. So previous 5 to 7, maybe have had a pseudo back in the day down at the bottom, but wasn't bothering her. Plan for a 3-level ACDF. Okay, go ahead. And again, early as well as late. I mean, the cages look great, and I think the experience is what we've been saying is just the lack of pseudoarthrosis. Certainly a worry about a failure here at the C6 level with the previous fusion down below, especially somebody with a little bit of that forward lean overall, that upper thoracic kyphosis. But you can go ahead to the next one, Bobby.
There you go.
And again, very solid fusion with this lady. This is the type that has become really the norm, and really is eliminating the need for posterior operations, in my opinion, pretty much, unless there's a significant deformity, in my opinion.
Good deal. So, question for you both, and I'll ask you first, Chambliss. Two things. One, what typical biologics are you using? Have you found that you're dialing back or you're able to use less hefty biologics as you had previously?
Yeah, pretty much just DBM. And to be honest, I mean, now the Inspire A-Lift cages, which is terrific. I'm very excited about that. The ability to, pretty much eliminate BMP and even multi-level A-lifts, I think, is going to be around the corner. And that's one of the things I'm most excited about is really just, I would love to just be bold enough to either put just only DBM and slash or nothing in the A-lift cages. I think, and I think that's going to be the next big study that is going to be a game changer. So being able to do 2-level A-lifts, a 4-to-1 A-lift with just DBM or preferably nothing, and see what we find.
Right. Okay, last question. I know we're at our time. With respect, I was looking at your all of your X-rays, Jeff's, Dan's, and Chambliss yours, and it was pretty obvious. Maybe a little more with the cervical, but the fixation's not changing. I mean, my experience with 3-4 level ACDFs with long plates is you'll see the screws change their angle over the course of their healing, usually because they're failing in some way. There's subtle subsidence. It may not be gross, but you definitely see sliding of the plates and screws that change their position because of that early structural integrity failure. Is it your experience that you're seeing less of that perhaps? I certainly didn't see it in these cases, but in general, anecdotally, are you also seeing
Yeah, no,
maintenance of fixation?
I completely agree with that, and I think that speaks to the cage, right? And if Dr. Harrod has his crazy idea about just putting DBM and A-lifts, my crazy idea with these cages is doing multiple level standalones with these, and I think the cage itself is going to hold it up. You know, don't even need plates for 3 or 4 level with these. That's my crazy idea, is how much I believe in these.
Good deal.
Yeah, I totally
All right.
agree. I used to use translational plates back in the day, especially for my multi-level ACDFs, and I mean it's a never event now.
Great. Any final words, Dan?
Yeah, I think I walk back my 100% 4-level ACDF failure rate comment, obviously. No, but I mean, in my own experience too, I mean, I think this is a really important point. I've had other users of this cage tell me that they are now doing more 3 levels than they've ever done before because they were so afraid of pseudo with the existing previous cage technology. And I think that echoes my practice as well. I mean, I'm doing 3 levels with significant more confidence going into the case. Whereas before I used to be really, really wary about, oh man, one of these levels is going to fail and I'm going to, et cetera, et cetera. I'm going to back this up. I don't have that really conversation around the 3 levels. I've done a couple 4 levels myself and had some good results. One of them, one pseudoed at the distal level and every other one fused on CT. So, it is what it is. But yeah, I think this has certainly given me more confidence in these larger constructs like we've seen.
Wonderful. All right, I think we're at our time. I want to thank Curtiva, Ed Madag, and the team there for helping put this on. And of course, Dan and Chambliss and Jeff. We got our good Southeast contingent with Dan and Chambliss and our Northeast contingent with Jeff. Appreciate you guys getting cases together and participating in the webinar. Good to see you all.
Have a great night.
Appreciate it. Thank you guys.